Hi, everyone, and welcome back to our next episode of ReWalk's Topics in Neuro Rehabilitation webcast. I'm Kathleen O'Donnell, and today we'll be talking with one of the therapists that we met during the Restore clinical trial, Matt Gifhorn. Matt is a physical therapist and a certified neurologic clinical specialist working at the Max Nader Center for Rehabilitation Technologies and Outcomes Research in the Shirley Ryan Ability Lab in Chicago. He has extensive experience working with projects involving lower extremity robotics. And today's talk will introduce some of the strategies that he uses when incorporating these technologies into clinical practice. Hi, Matt. It's great to talk with you today.
Hi, thanks for having me. So like Kathleen said, basically what I want to share with everybody is sort of a framework to use when thinking about incorporating exoskeletons or exosuits into clinical practice. I know that various facilities have different devices available to them or only have one available device. So it's just a way to conceptualize how we're implementing these robotic devices into our clinical setting. So the general framework I'll lay out here, and then we'll kind of go through one by one what I mean by each of these points here. So like any good physical therapist or therapist practice, you're going to identify deficits and impairments that you see in the patient. You know, you're looking at them from the same eye that you have in any therapy setting. So you're identifying strength impairments or endurance impairments or sensory deficits, and not just noticing that they're there, but how is that going to play into when you put them into the robotic device. From there, you want to set your objectives and goals. Again, very similar to things that we do as therapists every day. You want to be setting goals and objectives. You want to have a direction where you're going. Again, this is a goal specific to adding in the exoskeleton or the exosuit. So it's a little bit more of a targeted goal, but it's not that much different than what we're already pretty familiar with doing. So then you need to consider the actual technology that you're adding. So you want to leverage that technology so that its design and its features really are going to work with the patient and with your goals and those identified impairments so that you actually see success. Finally, you want to implement the intervention and plan. I'm not going to talk about it as much because I believe there's a little bit more detail in another topic, another talk coming up with a little bit more of the specific examples, but we'll hint on that. And because it also looks a little bit different for everybody and depending on what devices you're using. And then once you've done that, you want to reflect on the experience. So that could be after one session, that could be after 1 week, but really just thinking about, did I achieve the goals that I set out to? Did I leverage the technology? Did I do all of those things that I had prepared for? If I did, great, and why did it work? And if I did not, what do I need to change? So the first one, that identify deficits and impairments. So I think this is a skill that we all have as a therapist or really anyone working in healthcare, but neurologic conditions specifically, they present in a real wide variety. So not one diagnosis can have a really wide variety of presentations. So just because you had a spinal cord injury and you also know someone who has a spinal cord injury, those two people don't often look exactly the same. So kind of considering diagnosis, but more specifically how that diagnosis has impacted that person, because those individual impairments can impact how they're going to benefit from the device that you're planning to use. And then in thinking about impairments, you want to consider how the devices are controlled and how those impairments will sort of work with or potentially not work with the device that's available to you. So here's my example. In this case, I'm looking at stroke-related impairments. So you see you have quite a variety: strength, motor control, sensory, vision, endurance, cognition, arm and hand function. All of these things can be present, but they aren't always present either. So it really depends on who's in front of you and what the individual presents with, and then how that specific one will impact their ability to interact with the device. So kind of looking at this from a more framework standpoint, if you just take strength and motor control from this one, and we look ahead here, we had a little project that we did here that we had individuals who were randomized to a device group and individuals who were randomized to a non-device group. The intervention was stair climbing for 30 minutes. So if you look over on the left with the device group, person A we'll call a responder and person B we'll call a non-responder. And the big difference is here is that person A has some pretty significant strength impairments, but didn't have any motor control impairment. So no initiation issues. You say take some steps, they can. They just don't have the power to get their legs forward or whatever that may be. Person B does have some strength deficits, not as significant, but has that motor control impairment. So even though they want to take a step or they know that to take a step, the initiation is an issue. So in this case, this person didn't respond well to the device because the device isn't going to step for you. So if they can't initiate the step, they really can't benefit from the power that the device can provide. Flip side of that, the people in the non-device group will call person A responder and person B a non-responder. Again, had some muscle strength impairments, but not too severe. And I have unknown here as motor control impairment, but considering it was not documented, I'll assume that it wasn't really a factor. And person B had actually some more significant weakness and no motor control impairments, but since they were randomized to the device or the non-device group, they weren't able to benefit from the power that the device could have added. So really, you have similar presentations that are responding or non-responding, kind of depending on where they ended up, and that kind of speaks to that in a clinical trial. We don't really get to choose who goes in and who does not go into these devices, but in clinical practice, that's the beauty. You have a little bit more control over what you implement with your patients. So then you can kind of come up with these sort of formulas, if you will. So this is specific to the device group from the last slide. So if someone had weakness but is able to initiate a step, they're going to respond really well to implementing the robotic technology. On the flip side, if they have weakness but they aren't able to initiate the step, then may not respond to that technology. That doesn't mean that they shouldn't ever use an exoskeleton. It just means for this device and these impairments, they didn't really match up. And so I think every device or every person will have sort of their own formula that you sort of can come up with. And it will be unique to the person, but if you can kind of figure that out, utilizing the technology to match those impairments, you can see some pretty good responses. So then we've identified those impairments and the deficits, and we need to set our goals. Again, not terribly different than what we're comfortable doing as therapists, but they may be a little bit more specific. So things like increasing the number of steps in a 45-minute to 60-minute session, improving your endurance. That's a little bit of a more vague statement for sure. Increased step length, improved kinematics, improved posture, balance, better weight bearing for the legs. I think, we can identify that some of the conventional methods, we sacrifice some of those things like kinematics or weight bearing in order to get stepping or in order to get their heart rate high. And I think with some of the robotic devices, you can sort of get all of them, all of those goals kind of achieved at once. So, and then goals, how are you measuring your success? So clinically, we would use outcome measures, things like 6-minute walk test, 10-meter walk test. Definitely, you have a wide variety of things to pick from. But, kind of doing the pre-post or pre, mid, and post sort of assessments to see, has this been effective? So then leveraging the technology, considering the design of the devices. So this is not an exhaustive list, but quite a few of the commercially available devices that are out there. And I think you can kind of put them into the two categories, more impairment focused or what your goals are. So first we'll look at more from the goals or objective standpoint. Is this a therapeutic use or are you going to use this for personal mobility? So if I'm just planning to use this in the clinical setting, I can look at a little bit of a few more options. And then if the only goal of the person coming to therapy is personal mobility, your options are obviously a little bit more limited. And then going back to the impairment thing, the thought of does it cross single joint? Does it involve multiple joints? And here you see a kind of a list of different devices that the Honda and the Restore, they cover single joints, where the other devices are a little bit more robust and have both hip, knee, and kind of to a certain degree ankle involvement there. So you're leveraging the design of the technology to either attack one of your goals and objectives, or kind of go back to those impairments or deficits. So then, in addition to the design of the technology, you want to consider the features. So what features does the Exo-Suit or exoskeleton have that a conventional intervention can't necessarily add? And so I think you can kind of categorize these into three different features: assistance, resistance, and feedback. So assistance, in this example, we're using the Honda Walk Assist. So kind of going back to the slide before, it's a single joint hip flexion and extension assistive device. And in this study, the participants were randomized into a device or non-device group, and the group that used the device saw significant improvements in walking speed as well as periodic side step length, especially compared to the control group, who didn't see quite as good of improvements and didn't match the MCIDs, whereas the group in the assist device group did match those or exceed those. So then feedback, we have the Restore here, and what we like as therapists is that in real time I can see that stance time ratio change based on the cues I've given her. So as she responds to what the device is helping her do and what I'm cueing her to do, we're seeing changes in that stance time ratio. And I think also for the user, sometimes people are a little bit more of a visual learner. They like to see that bar is going towards the left when they, or towards the center of it when they do a certain thing. And so I think both the user and the therapist can benefit from that type of a feature. And then finally, we also have resistance. So in this one, you have Exo and 2 free. You can provide resistance at both of the joints there, and really challenge a more advanced user. She doesn't necessarily need the exoskeleton in order to walk, but it does allow us to provide a really consistent challenge across the intervention. So then implementation, you want to think about things that you would normally think about when you're doing any sort of intervention. Fit principles, so frequency, intensity, time, and type. And I think here, for the purposes of ours, it's that type. It's really where you figure out what device am I going to use in order to sort of to deliver the frequency, the intensity that I want. And kind of touching on that, the APTA clinical practice guidelines, certainly good to consider that. I think the robotic statement doesn't necessarily support its use right now, but the statement of moderate to high intensity gait training is strongly recommended. And I think that these devices can be used as tools to implement that recommended intervention. And then this is the big one. The reflect is really where you figure out, am I doing this right? Am I achieving my goals? And if not, what can I do to get better, or what device can I use as an alternate? So thinking about the setting where you're seeing the patient, acute, rehab, or outpatient, I think they all potentially have benefits. It leans a little more towards like rehab or outpatient, definitely, but certainly doesn't rule out anything in acute care. Determining the success, using your outcome measures. Again, that goes back to your goals. Was it to improve balance? Well, either BERG or FGA would be better there. Endurance, 6-minute walk test, gait speed, more 10-meter walk test. Did the user like it? There's many times a person gets out of a device and they didn't feel like it was worth their time, or it was worth the effort that it took. And other people think, I think I just achieved something I have not been able to achieve so far in rehab, and I think it's worth hearing their side of it. And then determining success, I think this is something that, we have talked about, Jill and Kathleen, that like when you implement a clinical trial, you don't have as much freedom to play with the settings. And in the clinical setting, if you aren't having success, you can just kind of change on the fly, or you can adapt and change use a different feature. Whereas sometimes in the clinical trials, the more research setting, you don't have that freedom. And then if it was successful, why was it successful? If it wasn't successful, why not? I think the second part's a little bit more obvious, but the first part is also important. What about it worked? And where do I go from here? Don't just, it's probably not going to continue to be the same settings and the same thing every day. You're going to have to think about the progression strategy. And if it wasn't successful, is it possibly because I, as a therapist, don't quite understand how this technology is working, like how the background stuff works? Do I not fully understand the device control mechanisms or that kind of thing? And if I feel like that's okay, maybe it's the impairments and the device control mechanisms aren't lining up. And maybe someone's just so anxious they can't focus on what they need to do. And maybe it's either have to talk with them about, is this something you want to continue? Do you think you can kind of get over that? Or maybe this is just not the right intervention for them at that time. And then that kind of goes back to sort of, maybe if that's in rehab, they can revisit this in outpatient when they're a little bit more comfortable moving in their body. I think that's all I have for you.
Right. Great. Thank you, Matt. That was a very, very helpful breakdown of kind of that thought process and flow. And I think it'll be really helpful for therapists, whether they have, a lot of different devices to choose from, but also if they have, one or two devices to choose from. I think the process really works well and fits in with kind of the clinical decision making that they're already doing. Just wanted to ask you a few questions. Yeah. So I think the first one, and I thought it was really interesting, the kind of mini study that you did about the stair climbers, where you categorized the responders and the non-responders. But can you talk a little bit about the outcome measures that you used in the cutoff thresholds to identify like who was a responder and what that really means versus a non-responder?
Yeah, definitely. So I think understanding that was as part of a clinical study, we used more of the statistics and statistically significant differences between pre and post outcomes, those types of things. We did the pretty standard battery. We also included the timed stair climb test, and then use things like MCIDs to verify whether they exceeded or didn't. And then, I think if you're looking at it just from a clinical standpoint, you don't have to get so specific with the stats and the numbers and all of that. You can kind of just go with either your basic outcome measures, and if you're seeing improvement, or if you're seeing qualitative improvements, there's some value to that too. It's not just about the numbers all the time. So that would be something to consider when you have it in the clinical setting as opposed to in a more structured research setting. Mm-hmm.
But in general, trying to choose an outcome measure that relates to the task that you're working on seems like that's kind of the path forward. Yeah, that makes sense. One of the other things that I really liked is you kind of did a nice job of breaking down a lot of the different types of exoskeletons and exosuits that are out there. And one of the distinctions that you made was, the difference between devices which assist at a single joint and devices which assist across multiple joints. But I wanted to know if you could talk about, for devices that assist at a single joint, does that mean that therapists should only be using them for patients that only have a deficit at just that one joint? Or do you see it as kind of a mix and match situation?
Yeah, I don't think you're limited to, if the device only operates at one joint, well, then they can only be impaired at that one joint, or you can only expect to see improvement at the joint there. Take, for example, a device that operates at the hip. It certainly is going to affect your knee. It's going to affect your entire step length. So therefore, where your foot hits the ground is a little bit different. The other thing is, if maybe in the stroke population, they have a more unilateral deficit, that doesn't mean they can't have assistance on both sides. You're probably going to see the most improvement probably at the joint that's being affected, or the limb that's more impaired, because there's more room for improvement, but I don't think that's the only area you're going to see improvement.
Yeah. Okay. So it sounds like you have to kind of take into consideration the whole kinematic chain.
Yeah, and I think it kind of goes back to like understanding the device operation, and even if you're using a more robust exoskeleton, if you've turned motors down at certain areas and, you know, they need assist at the left knee the most, yeah, you can keep that up, but then you maybe are in a more, a lower assistance, or even if you can combine resistance and assistance, that would be ideal. I don't know that devices are quite there yet where you can mix and match assistance and resistance in the same time, but
It'd be cool though.
yeah, it would be. But to say that you have the freedom to sort of manipulate each joint individually is really helpful. Some have the capability, some don't. And so kind of understanding what your capabilities are and where that play is kind of helps you decide what device to use.
And that actually kind of leads me into my next question, which is, once we've identified that device that we want to use, how would you then apply this framework kind of throughout that progression of the patient so that we can, you know, change the way that we're using the device as the patient progresses, whether it's the settings or the environment? What would your recommendations be there?
I think it depends on what feature of the device you're really trying to utilize. So if we're using a device that is going to give you assistance, right? Do you turn the assistance up high and kind of work your way down, but maintain the same activity? Would be one progression. Or you keep going, you try to start somewhere mid-level with the assistance force and sort of increase, but also increase how hard the device or how hard the task is. I think you could utilize both. It would sort of depend on where you're starting from, I suppose, with the patient in front of you. The devices do have some limits in terms of what environments you can use them in. So you have to kind of figure out where that upper limit is before you start using it, so you know kind of how close you are to it and where you really can, how far you can push it. Because you do have to consider safety, and if you're using devices with parameters that really weren't meant to be used, then you're putting everybody at risk. So I think there's different strategies. Resistance, I would say, you know, is a little bit more straightforward, where you kind of start low and kind of build, and then continue to progress the activity if you're already at the maximum resistance. Assistance gets a little bit trickier. Definitely, it's hard to know what's better. Either start low and gain assistance, but also keep the task hard, or start high and then start to pull away the assistance. That being said, I would think we always recommend training outside of the device for that carryover too. So
okay, so it's important to make sure that you have some period of time where you're training without assistance.
Yeah,
just to make sure that you're achieving that carryover.
Right. It's a device they're going home with. You know, ultimately their function outside of the device is what we're really trying to capture. So if you don't try to carry over what the device has been guiding them to do outside of it, I think you're losing a really big window of opportunity.
Yeah. And I think, you know, this sort of relates to that last question, but, you know, I know, you know, a lot of clinics don't necessarily have all the devices that Shirley Ryan necessarily has. So for clinics that may not have, you know, they may only have access to one or two of these robotic technologies, what are some suggestions or some of the things that they might be able to do, whether it's, again, adjusting the device settings, whether it's modifying that training environment, increasing the task, you know, difficulty level, or even using the device in conjunction with other tools in the clinic to really kind of expand that reach of what a device can do and which patients can use that device?
Yeah, I mean, I think it's a good point, because the reality is that you may have one option, and knowing what it can do, I think, is kind of your best tool.
Okay.
And knowing what its features are. And then kind of, if you see someone in front of you that you're thinking, okay, I think they need a little bit of that increased step length, or they need better push off or something to that effect, those are the easy ones, right? That kind of matches exactly what the device was designed for. But that being said, you know, it's okay to try something and then have that patient feedback be like, I don't like that, you know, and kind of feeling or hearing what they're feeling. As long as you're manipulating the settings within a reasonable level, it's okay for them to say, I didn't like how that felt. But that being said, if they said, I don't like how it feels, well, is that because you've changed their pattern of movement towards something that's better? Well, maybe you try to stick with that for a little bit. You can play with the settings. I think always safely warning someone you're going to change something, obviously, but That user feedback is also really important. Asking your colleagues, it's a little bit hard sometimes when you're guarding someone and you're looking at all the settings and the buttons, and you may not be able to take all of that in and look at the person themselves. So asking a colleague what you think, like this change in settings, did it help? Did it make things worse? I think that's kind of been a really valuable tool here. And sometimes, you know, it's just the device and the person may not mix very well, and kind of understanding that combination too is probably pretty important. To, if you only have one device and it's just not working, you don't have to force it either.
Right. And I think that's an important point, is that, you know, there's a lot of flexibility that you can have to try something and then reflect on, you know, as your last point of the framework is, let's try it out, let's reflect it. And as long as we're trying it in a safe way, we don't have to be afraid, and we don't have to be, you know, it's not always going to be perfect for every single patient, but we don't know sometimes until we try it out and try how it will really work.
And yeah, and a lot of devices, you're not going to see improvement the first time, the second time, the third time. There is a little bit of a learning curve with these things. So not getting discouraged if after one session they're not automatically walking 3 times faster. You know, it just doesn't happen quite that quickly. So sticking with it, as long as you feel like you're applying it safely, I think you got to give it a chance to show its benefit. So training with the device, making sure that you've kind of optimized to the person that you're using it with, doing a little training of the carryover outside of the device, and then kind of give it a chance to work. If it doesn't, then maybe you consider, you know, not continuing. But you can't give up after 1 to 2 sessions. There's a lot going on within those sessions that they're learning, they're changing. It may not feel comfortable right away, but if you stick with it, you may be able to see some pretty good, some pretty decent results. When you first start using anything new, you're really focused on the patient being safe and the device functioning the way you think it's going to. And that can take up pretty much all of your mental space. And then you don't have a whole lot left for the physical therapist part of you to watch their gait and to really comment on it and sort of also cue them to what they're supposed to be doing. Like, at first it can be a little bit overwhelming. So kind of having an extra set of hands or eyes, it puts you at ease a little bit and kind of actually helps you develop your skill set even more.
Well, Matt, thank you so much for a great talk, and thank you for your time. And to our viewers, we hope you tune in next week for our next episode. Have a great week, everyone.